Good evening and welcome to this meeting of the Adult Social Care and Health Select Committee. I am Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. The meeting is to be streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussions taking place. Now, I'd like to welcome you all to Committee Room 1 at Kensington Town Hall and ask that before we proceed with the meeting, can everyone present? Please make sure your mobiles are on silent or on switched off. Thank you, and we will now observe 72 seconds silence to remember those who lost their lives.
Thank you, Chair.
Thank you. Moving on to apologies of absence. Apologies of absence have been received from Councillor Stephen Petit and Councillor Mona Ahmed. Declarations of interest. Does any member have an interest to declare? Minutes from the previous meetings. The minutes of the meeting held on the 12th of February 2026 have been submitted for confirmation. Does the committee agree that it will be signed as a correct record? And moving on to agenda item 4, home care mobilisation. This report updates the Select Committee on the mobilisation of the new arrangements for commissioning home care. This is a very important service which supports many of our vulnerable residents and is very timely to discuss the report now as mobilisation has started with providers, including the new place-based model in our neighbourhoods. I think Councillor Josh Randall is running a little late, but we have you.
Yes, would you like me to provide an introduction?
Yes, please.
Okay, thank you very much. And thanks for asking us to bring this paper to the committee. We've spoken to you a number of times about home care delivery and about the proposal of design procurement for this new model, but now at the stage of mobilising. And so just as a reminder, this is the first time we've fully decommissioned our home care services since 2014, when that took place as part of the Tri-Borough. The work to design this recommissioning model took probably over 18 months in total to do, running a number of pilots to try out different things, working very closely with residents and carers, with providers in the home care market, and of course with our social work teams and colleagues in the NHS. The core of the model, I suppose, does stay the same. We're working in geographical areas, but 4 of them now, rather than 3, reflecting the demand, reflecting how we're looking to manage some of the market, to make sure that we can attract staff to work in the borough, particularly local staff to work for agencies in the borough, and crucially to retain those staff so that we can do as much as possible to provide continuity of care with the same care workers and going into families' homes. So we have 4 neighbourhood lots now, working through quite just very well. But in addition to the 4 neighbourhood patches or neighbourhood areas, there are 3 other what we call lots to the procurement framework. And this is also something that we've driven us to address particular areas of and some specialisms, but also to ensure that our quality and contract oversight is as tight as possible. And in the past, we've had the geographical areas, as I said, 3 of them, And over time, sometimes those agencies weren't always able to take the number of referrals that were coming through to them. So in those instances, our brokerage teams would have to call up other agencies to say, could you help us out with this situation? So we had quite a proliferation of what we call spot providers. Now, spot providers have a contract, but because there's a number of them, it's difficult to contract management and quality assuring in the same way that we ideally like to through our usual processes. So lot 2 of this new framework is what we call spot providers, but they're contracted spot providers, and they will be overseen in the same way as all the other organisations will be. Now, the following 2 lots, lot 3 and 4, are, as I say, designed to address some areas where we want to pay some particular attention, and where residents have said that they think they would benefit from having some specialist organisations. One of those is what we've called complex by exception. So where people have particular conditions or particular types of care that an ordinary home care agency might struggle with. These organisations will have staff with particular specialist training that will be able to address particularly complex needs, and that might be complex in terms of behaviour or like to working with community health specialists in particular, and physios, etc. And then the last lot, lot 4, is what we call the bridging and reablement service. Again, that's something we've learned a lot through working with the NHS and through pilots in designing this. And it's effectively about helping to get people out of hospital as quickly as possible, and that's not the best place to intervene. That's what the bridging service enables. And reablement is a provision that home care agencies will be able to deliver for us before. But it has, again, a particular set of skills that are designed to get people back on their feet, but they don't really need a long-term service afterwards. So we're looking to make sure that those agencies have staff with training in those particular areas. So that's the setup. In terms of the mobilisation, it's happening in 3 phases, as you'll see from the paper. Onboarding of all the new contracted providers. And in RBKC, there are 20 providers, 22 overall if we think about it in a bylaw. But 20 of them will be working in RBKC. And they've all been onboarded through the simple venue initiatives. And we've been in the process of mobilising lots 2 to 4 spot providers, the complex providers, and the bridging and reablement. That got slightly hampered by the cyber attack, but we can put some contingency in there, and we're working to a timescale that we're comfortable. The longer bit of mobilisation is the staggered implementation of the neighbourhood model. And we've been deliberately very careful about that. It's set out in particularly on paragraph 4.3 of the report in that section. And the reason that this will take a long time, and probably up to a year, is because predominantly these agencies are working with people who are already receiving care from an agency. And so we want to have individual conversations with them, families and carers about the process of change. People have been written to so that they've got an awareness that change is coming. But in some instances, it might mean a change of care organisation. It could mean a change of actual care worker, although not necessarily, because people are cheaper from one organisation to another. The timescale of that is that those conversations will best take place because they have to happen with a social worker as part of somebody's annual review process. So if everybody gets at least an annual review as part of their care package, and it's mobilisation working throughout that period. And one thing that we're keeping a really close eye on is as some providers leave working with us and others come on with the new on stream, taking on more and more work, that we aren't destabilising local provision. What we've seen sometimes in other parts of the country is when you make this change, it happens too quickly. The outgoing providers use a number of cases that they're working with on getting the same income, and then suddenly have to hand everything back all at once. And we don't have capacity for that sort of change. So we're taking a deliberately staggered approach. It doesn't cost us any more because we're paying activity in different ways, but the key point there is stabilisation. We're really proud of the kind of work that's happened to kind of design this new model. We're getting lots of interest from other local authorities in terms of how we set it up. It's benefited from some piloting work that we've done here, some piloting work that was done in Westminster in particular around paying for people's travel time. And we think that as a by borough, we're now in a position to be quite unusual in London, probably unusual in the country, to have really got under the skin of how travel time pay actually works. And what tends to happen in a lot of places is we say we're paying under the wage for the hour rate, but then the time it takes for somebody to get from one place to another, that London living wage erodes, but it stays at the national minimum wage. So what we recognise here is getting from one place to another. That's somebody's time they're working, they should be paid for it. So all of these contracted providers have in their contract to pay at the London living wage for the time it takes to get from one place to another. We check that through people's pay slips. And a really good thing for us in terms of staff satisfaction and that point around retention to people with their service users. I think that's the main things that I want to say. One other thing, just in terms of the contracting, is the quality of the design of this service. Now, we've got a lot of interest from the market. 111 organisations did this. We reviewed, gosh, I've lost my numbers now, but 111 at stage 1 and then 36 at stage 2 to get down to the final 20. All of them really high quality, particularly at that second stage. So we were really pleased with that. And it helped a lot as well. So in the tender evaluations, one of the questions was designed by residents who helped us with an area with the particular priority for them. And that's set out in, I think, Appendix G.
Thank you, Karen. Josh, you want to add anything?
No, I think Gareth has done very well. I mean, as you know, it's quite Gareth and the team have done an amazing job at this. I think it's been a real team effort to get this far, but no, so I thank the Commission team, Gareth, for getting this across the line.
Thank you. And thank you for the paper and knowing that it's included. It's very helpful. I think one area I wanted to ask initially on was just discussing continuity of care, which actually sits at the heart of the model. And as you mentioned, and the report mentions, it's not necessarily guaranteed residents will be able to keep the same care worker. So just to start, sort of in terms of continuity, what disruption could we expect in practice? And sort of how are we identifying and protecting residents most at risk from potential change in care worker who might have sort of anxiety or more complex needs, and that the continuity of person is much more significant.
Yeah, it's, like I said, it's been one of the main areas of focus for us in planning the mobilisation process, and the whole design of the service to try and retain people in those roles. Chiefly has applied, so 3 of the 4 new neighbourhood providers are providers who worked with us under the previous model. So that helps quite a lot. With they're good providers. One of them, we remember, we've worked with Fighting Cancer through an improvement period where their CQC rating had dropped, but they are a good provider now. And there's one new provider there because we've got a larger patch, but cheaply is applying. So it's the staff are given the opportunity to move across to the new provider. And what we've set out in discussions with residents so far and in letters that we've communicated to them is our ambition will be to make sure that they have continuity of care wherever possible. That if for some reason the member of staff doesn't cheaply across to the new organisation, that doesn't mean that if that's the number 1 priority for them, but there are other ways that it can happen. It's not ideal because we want to have everything within the compliant contract arrangement, gives us better quality and contract oversight. But people might be able to do that through choosing to take a direct payment, for example, and working with the agency where that staff member still is directly, or hiring that staff member as an assistant. So that in those review discussions, there are opportunities to look at how that we're anticipating should be designed for a lot of that good stuff. And I suppose in reality, there's always a degree of churn in home care. So it's something that isn't unusual for people to experience when staff members come and go. But we're trying to minimise that disruption.
It's work on this as well from residents or from councils as well regarding changes of care workers. It can be really distressing for obviously a lot of the residents that have built a relationship with someone in particular. As Gareth said, I think the direct payments is a really good way. But I think we're the second best for direct payments as well. So I think what we encourage our residents who are on the system to use that the most because they can get a bit of sovereignty over what they have and what they can choose. So always really encouraging people to kind of go down those lines. I think we're really careful and really understanding of people who do have issues.
Yeah.
When that can change. I mean, change is not good for anyone, but we're just trying to obviously have that process out. But again, we get frequent, not frequent, but we get enough to recognise that this can be really distressing for some people. But I think we work really, really well in order to ensure that doesn't happen. So yes, Gareth, great.
That's very reassuring. I'm just going to ask one last question, then I will move on to the rest. Just in terms of the sort of mobilisation risk, and obviously it being a very large scale transition of 1,000 care packages, I think it'd just be good to understand what the biggest risks are or will be during mobilisation, and how confident you are with current timelines and that it's safe and deliverable.
That should be done with that slightly, because it did affect our time test for one part mobilisation, but like I said, we've managed to resolve that. The biggest risk, I think, and we've done quite a lot of talking to other boroughs and other counties and places in the country that only sort of about it, is the withdrawals providers. And it not only messes with the kind of plan and the timing, but it means a lot of disruption for individuals, and actually it can increase costs for the organisation, and so you can actually kind of very, very tightly manage where we are financially. But that would I'd say the kind of the number one is the loss of the organisation's during the process. And it's similar to that, I think it is going to work if people on the team. So like our social care teams and our commissioning teams who are overseeing this mobilisation process. Whilst it's kind of all planned out, documented, too much disruption on that side could create some difficulties for us as well. If there are lots of people who choose to switch to direct payments, that would require a change in the action of our mobilisation plan. We'd have to shift some of our resources to switch to help people set up with that. It would be a good thing, I suppose, as Josh said, because it's a target class to increase that. But anything that disrupts the plan as it is on that sort of basis, and meaning that we have to shift resources as well.
Okay, you guys, if you want to start already, initial questions.
I'll start. Thank you, Gareth. And we've heard quite a lot about this over the last few months, so it's good to see this paper come here and everything being mobilised and everything moving forward. So I did want to ask a couple of questions. You know, you've always talked to me about how unstable the market is for these providers. So I was kind of surprised to hear how many put themselves forward. So has something changed? Have things improved? It's quite a lot.
Yeah, it's a question we often get asked by the CQC, by Department of Health and Social Care, and ADAS, the Association of Directors of Adult Social Services, is they do annual surveys and sometimes they'll pick up and they'll ask how many contracts have you had handed back in 12 months. And we've been really fortunate that we haven't had in for a long time. And partly that's because the way we manage relationships with organisations, but comparatively across London, we're probably usually kind of top quartile payer in terms of the rates that we offer. And I think a lot of that has led to the sort of interest that we got in the tender that we put out. There was also a lot of care that we took in iterations and rounds of market engagement, helping organisations to understand what we were looking for and to get their input and their expertise from other places on other things that we could think about that perhaps we hadn't considered. And we piloted some things over that period of design to see whether they should be done around. So organisations that we work with and lots of organisations that don't sort of knew where we were going, and we trialled long in advance the timelines for when we were going live. So all of that market engagement side had been very thorough. you're 111 is a lot in terms of you would imagine there are 111 home care agencies in London. And some of them are relatively short-lived, some of them are quite specialist, small, so weren't necessarily going to be right for a lot of these, hence 111 went down to 36 and relatively quickly, getting across the bars that we set out first page. It was quite high. The 111 were all rated good by the CQC, but they'd all had an inspection. If you look on the CQC's books, there are quite a lot of home care agencies on there who haven't had an inspection yet, so don't have a rating. We were only interested if they had a rating. So I think it was the amount of market engagement that we've done, the kind of quality of thinking and the design, and the transparency and I think the sort of fairness in what we were talking about in terms of remuneration helped. One other point on that, which we've had some debate on here, and as you look at leadership teams, well, it's about the length of contracts. And so we're often in the public sector cautious about issuing longer contracts because we're concerned that it ties us into certain terms and conditions over a period of time when we know our revenue position is becoming more challenging at the coming years. But in social care here and in other parts of London, we've seen increasing use of longer term contracts, so 9-10 years, done on multiple, so 3 years to start with, then plus 3 years, and then plus 3 years, which gives us some assurance in being able to change things if we need to. And it also signals to the market we're investing in this for the long term. It's not something that's going to stop shortly on this doesn't change nationally.
And I think people want to come and work with RBKC too. I mean, not for every 10, I must admit, but for a lot of them, we do get really good, high quality people coming to submit their bids to the RFP. And I think that's really, really positive. I think for a couple of reasons. One, obviously, we're a great borough. They know the services that we provide. Some of our residents, obviously, we've got CQC outstanding. We're pretty stable as well. Some other parts, there's rarely any political meddling in the commission services, which does happen in other councils. Please say maybe Gav has a review, but we don't do that here. But we do scrutinise really, really tough on spend. And a lot of the commission services now are coming for evaluation in decisions overall, rather than just me, because we need to ensure that we're getting the best value for money as possible, just given the real challenging market we've got in the with all the fairer funding as well. But I think that gives people stability and a sense of direction as well. And I think that's a really positive thing to do too. And I think as well, people like challenge. People like coming to working in central London as well. It's a different, perhaps, a position than they maybe kind of used to in other parts of the world.
I think it's really impressive. I mean, given some of the issues that we've had to hear all of this, it's really great. And then just one other quick question, which is about the engagement and the residents that you spoke to. And I guess my question here is, what were they raising? What were some of the themes that you heard from that consultation from the residents? And I just kind of asked that because that helps us sort of think about what we should be asking. What were they saying to you about that?
Yeah, some of that's reflected in one of the appendices about the programme that has some of the assignments from they're based on people that we spoke to. You can see from that too the question the residents. So we spoke to the local account throughout this, which have been sort of central to the design, but not just the local account group, because they're brilliant, but it's a relatively group of people. And so we had a lot of sessions that have been put together with our social work teams and with both people with the drawing and care support, but also their family care units to give them as well. There was a lot of focus on and the sort of team that are around family and how flexibility was a kind of key point. So being able to make changes to the times of day that people might come as a way things will happen, being able to get in touch with people quickly for those changes. The connection between the care worker staff and colleagues working in the NHS, particularly people who also receive support from allied health professionals or when they're talking to their GPs, knowing that the care plan updates, the staff for a home care agency come back to our social content and share the tutor as well. So that there's around that movement. And it's really helpful for us that that's the sort of thing that residents say, because one of the things that we're constantly trying to do, and particularly now trying to do more of in developing neighbourhood health services, which is a big part of the NHS's plan locally, who's trying to do, is think about the development of sort of multidisciplinary teams of individuals, and more so than we have been able to do before. And that's always been really difficult to do with home care agencies because they're on an hourly rate. So kind of getting them around the table with social care or health providers is quite difficult to do sometimes. So the fact that residents have said to us that's an important thing to them is that we can start to build that into some of our workings through the use of provider forums and through forums where home care staff can provide feedback, not in a kind of weekly multidisciplinary meeting, but we can generally get that.
Right, thank you.
Thank you. No, thank you for that. And obviously, this is a complex issue, and you've been here time and time again on different aspects of this. And some of us go back to the Chelsea Care Days and all of that. So this is a really encouraging paper, and let's wish it well. Just a few questions really. 20 providers. That sounds a lot in terms of managing them. So what you get, don't you, with these sort of is very keen to get the contract, keen to be good in the first year. But then the ongoing management of the service delivery can be a real challenge. I'm just wondering whether what's your thinking of the ongoing management of the service level?
Yeah, that's a good question because we've got a limited number of contract managers and quality assurance staff. And the degree of time that is spent contract managing and quality assuring the providers is proportionate to the amount of activity that we can see on that front. But most of the attention that we will give, as you'd imagine, would be to the providers in Lot 1 who are delivering on the neighbourhood areas. That's where the bulk of the activity is, the most volume, the highest volume of individuals receiving care. And most of that contract management time will be spent there. The 10 providers that are in Lot 2 as the contracted spot providers, we anticipate that they should, maybe about 18 months down the line, have somewhere between 5 and 10% of the business. And so the amount of time that we have to spend contract managing them, in addition to what CQC is doing, for example, will be lighter touch. There won't be so much activity that there will be some points of assurance that we want to make sure are covered. And for the complex by exception, again, it's a much more group of organisations. Leopold does have a list of about 8 providers. But again, I would anticipate of those 8 will probably be working with 2 more consistently than
And on the neighbourhood side, how many providers will there be? Or just four providers?
One main one for each neighbourhood.
And I see looking at the map, some of the areas have got 2 or 3, the wards are overlapping, some wards are in 2 areas. That's
So that map's been drawn kind of purely on the basis of where the activity is.
so Chelsea, the whole of Chelsea is one area, but
There's less activity. We provide less home care in Chelsea. We've tried to make it as equitable as possible so that the number of hours that a provider can expect to achieve that can broadly out.
good. So wish you well. And just on the direct payments, and you're right, but I found casework that if direct payment goes well, it goes well. Once it goes wrong, residents can get themselves in a real mess. And I guess it's how we manage that. And often people can start on direct payments, but as they get older and less capable of managing that, it can then become a problem.
One of the things that that's been successful is the establishment of a dedicated direct payments team.
Right.
And you see it in the social work team. And they're there to deal with that sort of thing. Having that team does what Catherine said in terms of driving up the number of people who want to use direct payments, which is great. And so when things break down or when circumstances change, there's a dedicated team there to help them deal with that. And if they want to move out of direct payment back into the commission service.
We also work really closely with AGKC as well. I mean, they're really supporters of direct payments, so especially with working well for some of their members as well. Well, there are residents in that part. But we also hear from them too when things aren't going to direct as well. And that, we're working on a project with them at the minute to try and make direct payments work better. for people who do that as well. So I think we do hear from multiple sources where it works and where it doesn't work, but the team's really good. I've met them a few times. The direct payments team, I mean, there's a ton of reviews that we do get are really good. Again, there's not always, I think it's always perfect, it can't be, but I think we do a pretty good job on what there is in regard to that.
Great. Roger.
Thank you, Chair. And thank you, Garrett, for all your work on this transition. Well appreciated. And also for your very informative report. I just wanted to ask you two questions. How will you ensure no missed care visit during transition, especially a double-handed care? And what is the escalation protocol if safeguarded incidents during transition? Is there a protocol for that?
The safeguarding protocol doesn't change. So an agency's contracted with us under the previous arrangement, and that contract, they'll just do working to that contract until the particular package of care switches to a new provider. Both of them will be working to exactly the same safeguarding protocol in terms of referring to our safeguarding team. So that's absolutely opportune. So do you mind me your first question?
How will you ensure that there will be a no miss care visit during transfer, especially a double-handed care?
Yeah, there are some of those sort of technical and practical bits of the arrangements that we've really sort of tightened up under this model. Missed visits is one of them, and we don't get lots of those. But it's really, we've been much more explicit about it, and the penalties for it happening, it does happen in the contract. Our we're really clear. Similarly, there's a quite strict protocol around I suppose the opposite of that, where there are no replies, where our home care worker goes to somebody else, knocks on the door, and they're not getting a response. The amount of protocol that we have in place, check and triple check, double and triple check that, and it's really impressive in things that we've got. So like there's limited risk of an individual being on the home on the floor because they can't get to answer the door, and the person will come away, because the home care agency runs through all the checks, and then our team runs through all the checks, and they check with GPs and hospitals, etc., to check that something else isn't there. And one of the opportunities that we've got through this new model, particularly around your question about missed visits, is that tended to happen with the complex by exception cases, and sometimes with the batch cases. So we didn't have a complex by exception set providers, and they're there particularly to do what we used to call the patch providers, the old three neighbourhood providers. Did occasionally struggle with getting two people for a double-handed package of care at the door at the same time, and somebody you can't do manual handling on your own. It's a two-handed package, so that could sometimes cause a problem. Those sorts of cases are more likely to be handled by the complex by exception providers, who are set up specially to deal with those sorts of arrangements where people need to use hoists, where there are particular mechanisms that they need. That's what those agencies are for. And similarly, there are the stronger expectations on that patch providers. So it's one of those things that we've taken into account in the design of this, and it's in the setup of the lots, but in the context for the patch providers too.
Thank you.
Thank you. Matthew.
Thank you, Andrew. You mentioned that some other boroughs had come and approached you and said, what a great service. I mean, I guess it's less borough specific, but I think probably people would be slightly concerned to think that you live a few roads north in Brent or east, in Westminster West and West Hampton, or in other boroughs and parts of the country that you're essentially subject to a postcode lottery in terms of your social care. I was just wondering what sort of conversations we have on a regular basis with other boroughs and other local authorities to make sure that we're always at the forefront of the best possible care, but also that we're sharing best practice with others to try and make sure there are fewer inequalities and disparities across, I guess, London and local authorities more widely.
Yeah, our commissioners for this service are part of the London-wide commissioning network, and they have regular discussions, sharing the practices, sharing where things have gone on, and we can learn from this. And that's been factored into this model, but that's these quarterly as a commissioning group, and often they'll be talking about home care because such a large part of business, but sometimes it's equipment, sometimes care homes, but that's our mechanism for doing that. And when we're doing a particular piece of work like this on home care, the people in other boroughs who focus on home care all know each other fairly well. So the example I talked about here, where we give a particular focus on travel time, our others, and which is the other one, that I've really tried to kind of get under the skin of how that works in agencies and get them to be much more transparent with us, doing all the looking through of pay slips for people, mapping travel times on average between the agencies use a mapping tool to plot out someone's route for the day. So you can work out what the timescales would be for somebody's travel.
There's a lot of work. I'm interested how do you calculate that. That was the other question. How do you calculate? I mean, obviously, if I walk to work, it takes me a lot longer than if I get tube well, get cycle or other things.
Yeah, I mean, agencies have a tool. It's not Google Maps, but it's some people use a version of that to plot the most optimum route for staff, so that people aren't having to travel too much. And we used some of those tools to sort of re-engineer what those timescales look like to then work out what an average requires for travel time. But I suppose the other thing in your question is that different boroughs have different challenges. So when we talk to them, their travel time issues are very different to us because they're more distant to travel. Often, the outer London boroughs have much more of a challenge with that type of issue. Some boroughs have more. Some boroughs would really struggle to get the 111 days that we got because there aren't the agencies that far after them. And so we've done a lot of talking to other boroughs about the market engagement approach that we've got to effectively build market interest. And so the networking across London, to a degree, for other parts of the country, is how that happens. And there are a few specialist or sort of think tank organisations, I suppose, who've got an interest in this area of business that also help us in the thinking that's gone.
And you mentioned outside of London as well. So is there a similar group with other local authorities across the country, or how would that work?
So that's mostly helped by ADAS, which is the Association of Directors of Adult Social Services, and as a national organisation, it has sort of regional branches, so they're part of the London branch. Sometimes we talk to the South East branch or the West Midlands branch if they're doing something particularly interesting. And ADAS nationally helps to cross-fertilise funds.
Thank you. But Charles, it's crazy how closing of the Westway for a month has clogged up Notting Hill. So if the travel times in Notting Hill are going to be twice as long if you present it by car, then so it must be. I mean, it's a whole science in itself, isn't it, or an art if it's not a science.
Would that then be taken into account, or would you have a standard? This is how much your travel normally takes.
It would. What we said in terms of travel time in the contracts is that there is an average kind of distance time between visits, and it's errs on the generous side because the way that routing develops means that actually most people are able to walk between visits on driving. The way we've got those geographical patches set up make that much more likely. However, there will be occasions where somebody is asked to kind of help out the borough because something else, and where there are these exceptions through certain contracts, that we expect that to see reflected in this.
I was just going to ask a question on sort of forward thinking and what success looks like, particularly for this committee in due course. So just kind of key idea of what indicators we and whatever this next committee is should look for in the first year to assess whether this is working and how successful the new model is.
Key ones for me would be the feedback that we're getting from residents. So the number of complaints that we're getting, and the sessions that we're planning to hold with service users who are part of the design to follow up with that. And the feedback that we'll get from social workers who are undertaking those open reviews to test the temperature of how that change is going with people. Managing that key risk that I talked about in terms of stability of the market. And then the other metric that we always measure, where I'm interested to see what changes are the recruitment and retention rates in agencies. And I really expect that you've got a very high retention rate in comparatively for anchor agencies. So I'd expect to see that go up. There'll be some sideways effect on that, for instance, changes that will come from the Employment Rights Act, which will do things like make changes to statutory sick time, so we're not seeing some interference with those measures, but we'll take that into account.
And when do you think it's sort of best for next come back to this committee?
I always say that I come back to it. This is often as you like.
You're always very pleased with it, aren't you?
I did.
You've done amazing work.
I suppose in terms of that mobilisation period, when might be a good time to actually see some difference, get some of that feedback. We're planning on the deal in terms of maybe something before then, and then I'll sort of temperature test as the mobilisations.
Yeah.
And then when we get to 12-18 months.
Okay, that's good to know. I think that's it.
Last bit from me, if I may, Chair. I'd just like to say this is Garrett's last meeting with us and Adult Social Care, going off to bigger and better things. Still in RBKC, but leaving the team overall. And I'd just like to thank everything that you've done. You've always been such a stable force, and one of the reasons as well, which I've really respected. And your knowledge of the commissioning service, scrutiny, especially governance of the council, I think is really outstanding. But and all we work obviously on NRS when we had that issue, and now cyber, which Garrett is going to work on now full time on cyber recovery within the chief executive team. So just wishing you all the very best. We will miss you in Adult Social Care. And yeah, thank you for everything, especially this is your last hurrah. Thank you.
Thank you. I'm glad you're staying in RBKC.
I'm still going to call you,
If this goes wrong, you might hear you now.
Great. Moving on to agenda item 5, which is the Director of Public Health Annual Report. This year's Annual Director of Public Health Report focuses on the health and well-being of aged children. In the borough, it is based on the results of a survey of children's experiences, which we're very pleased to be discussing in the select committee because of the research that it presents children's lived experiences, priorities, and perspectives about that of the market. Josh, Hilary Shaw, and everybody. So I don't know who.
I can start off. Thank you. I'd like to welcome a special guest star. Hilary, who's usually obviously with our children's services, comes to the children's services committee a lot, but who's here from helping with the educational school bit as well. But this has been a really interesting report that Public Health have done for the report for this year regarding children. I think we spoke about this about 12 months ago when we started about going out to children, or as you can see in the report, different age groups, different years, just to get their feelings on how they are in the borough regarding their health, and that can come from mental health, physical health, healthy eating, housing, everything like that. And it's come up with some really interesting results. I think I said to Anna at the time, we need to go to school, survey schools, ask them questions at a time. It's a bit exhausting, I think, that we're actually going to get any pickup from any of the stuff, because obviously we're asking them all the time about different elements, but I think we have a really good response rate, actually. Over 1,000 people, I think, or something, we're reading for this as well. But it's a good way to see where we are, how young people are, and the direction of travel that they're in. We do something really good here, something not so good, especially I think oral health still is one of the major repercussions we have. Mental health came up a lot, and that's in various capacities, anxiety to the real mental health issues as well, and things about STIs, drugs, and all that kind of stuff, especially for obviously the older kids more than the younger ones as well. But it's kind of good to see the direction of travel where it's going on, and I think the report is really good, child friendly as well. The voice of the child, I think, really comes through. Looking at potentially next steps, as I said, on oral health is a major one. That's in a report that's kind of a section of its own supplementary parts. And I don't think what Hilary did.
I just kind of say behind every annual public health course is a team, and this year it was a really good opportunity to join up with our colleagues and children. We work very closely with our colleagues and children's services all the time, but particularly the opportunity to come together to get an understanding of children's voice. We've got nearly 2,000 children's voices in this survey, so it's quite a unique survey. In that it's hearing from children and people in their own words, in their own voices, what they believe their health and wellbeing needs are. We're going to get an awful lot of use over this survey over a number of years, and we'll replicate it every 2 years. And also our North Kensington schools will have the opportunity to participate in the survey every year. So it's given us some really good baseline information for children's health and wellbeing in North Kensington, that we can do a more intensive piece of work with those schools. And the other thing just to flag is the schools who participated in the survey also received a grant to undertake work in their school setting in relation to the results of the survey. So each school got their own individual report on the back of the survey, and some examples of the ways in which the school would have used their little part of grant funding up here. So, for example, some schools have set up regulation zones in the classroom, which is an area children can go to if they're feeling upset or anxious, until they're ready to re-engage with the classes again. Lots of other examples. Please do questions and individually. Just start.
Or anyone else want to add anything? Thank you very much for this report, and it's very welcomed, and particularly sort of emphasis on prevention, early intervention, and partnership working. I think it also sort of raises some concerning areas, which sort of around emotional well-being, bullying, online harm, unhealthy grades, vaping, and obviously the very unequal ways some of these issues are experienced across the borough, which is not new to this committee. So I would love the committee to focus not just on the value themselves, but on sort of what is going to change as a result of doing this work, and the impact, how the impact will be measured, and whether support is reaching the children most at risk. So I just wanted to start by asking, I guess, how will the findings from this report concretely change services investment or delivery over the next 12 months? And I know you said regarding North Kensington schools can participate every year. Is it therefore voluntary to the rest of the borough and the schools that participated this year if they want to be doing it every year? And sort of how are we going to have a full picture as to kind of how we're measuring the success of the investment and what is going to come following this in future years to come?
So all our schools, including our special schools, have the opportunity to engage every second year. We decided to do the focus on North Kensington, particularly because the decision for the tower to come down. So it gave us a little bit of baseline information before the tower came down, but it also enables us to just deep dive to monitor their health and well-being over the next few years while there's significant transition happening in that patch. But we wanted really to be able to support schools, particularly to understand children's mental and emotional wellbeing needs during this time. So that's the purpose for the focus on North Kensington. There is also a North Kensington report that specifically looks at those North Kensington health and wellbeing needs of children alongside it. But I'll ask if there's one, and Hilary wants to say a little bit about how data can be used and how.
Yes, if I may, and I think it's recognising that in advance of the survey, schools did have and do have arrangements in place to support the children in terms of their emotional well-being and their engagement and partnership with other services, some of which are voluntary organisations. Some of them may have heard of Place to Be, for example, or investing in counselling as part of their overall pastoral system. But the benefits of this are that all our children in our schools are being asked. We have So, you know, pupil councils, etc. So they are a lot more familiar in being asked, you know, what are your needs? And they kind of, you told us and we did approach. So what's enhanced here even further is bringing their voice into determining what services might look like, what's helpful. It's always useful to find out what isn't helpful or less helpful, and addressing some of the issues that are emerging. For example, you will have seen in the report about vaping.
Yeah.
And there is a general kind of myth or belief out there that vaping is okay, it's safe, in inverted commas. I'll be corrected by you, Anna, if I've got this wrong. I've learned a lot from my public health colleagues for education. But I think, you know, if you're a smoker and you're stepping down to vaping, you know, that's different. That's a step in the right direction. But this is to do with children who are experimenting and trying vaping. So I don't know if you want to hear about Project Adder. I can just summarise it in 2 sentences. Well, there you go. I can't take credit for the title of the project, Project Adder. That comes from police colleagues. But this is an exercise which a number of schools are participating in, and it sits within this context of the report we've got before you. But it's about children who sometimes, you know, take vapes into schools. You know, one school where they've got a detector and they know when it's happening, vaping. And of course, the vapes are taken from the children, they're confiscated, because it's not a good thing for them to be having. And Project Adder, what they do is that the police come and collect the vapes that have been confiscated. This is not about criminalising our young people. It's very much about their health, because what we do know is sometimes the vapes contain quite toxic and worrying contents that can have an effect on children. Not that I'm saying it's great for vaping at all.
Is that because of them purchasing ones that are not legal?
So I can,
Yeah. No, go ahead.
Yeah, so our training standards team and part of
Yeah,
environmental
that's
health
right.
often go out in the parts of the borough and do spot checks on a lot of shops who are selling illegal vapes. So vapes are obviously legal in the UK, but there are elements, especially ones imported from the United States, which have much more nicotine or other chemicals in them that aren't appropriate for anyone, let alone those under 18 years old. And environmental health and training standards do spot checks on this. In fact, they do use young people to go into see if they're going to sell to someone under the age of 18, which in some cases they do. In that case, the shop rated investigated as well. So obviously, there's only finite resource trade standards, but they do that best way they possibly can. It's obviously not just an application issue; it's an everywhere issue as well. But you know, trying to take that on, you know, obviously has impacts on people legally as well. So obviously it's a council-wide approach and health-wide approach as well to do that too. So like you said, Chair, it is the shops that can have to, because they're not enforcing the way they should. And they're selling things that are illegal. But there's separate teams that do that. But obviously Hillary in Children's Services works closely with schools, and obviously Anna as well, from the public health perspective, trying to encourage that message. I think the challenge is that it's cool to vape rather than no one looks at the the danger of it more so than anything else.
Anxiety.
Yeah,
Is
exactly.
there any evidence the other way? Children start with vaping as an entry and then go on to smoking, or
So I think they are starting to see some trends in that direction, which are very, very worrying, because what we've got to remember is nicotine is one of the most highly addictive substances in the world. So exposing children to vapes and to vaping is getting them addicted to a substance. And then once that addiction is there, then it's probably quite easy to go in the direction of cigarettes. So yeah, it's very concerning at the moment.
Very conscious. We just cut you off.
That's okay. I think, but you were absolutely right in asking, now we have this information and there's a modest grant that goes to schools. It's where schools draw up an action plan, and that's in collaboration with their school community as well. So we will be reviewing impact with them and hearing from the children very importantly as well. And I know you'll have read all of this, but while some of this may be seen as more in the sort of secondary school phase, we did do the questionnaire of children in years 4 and 6 in some of our primary schools as well. But what it's revealed is that, online stuff and the vulnerabilities associated with online and what children have been exposed to and what they've seen. But also it's about bullying that could be face to face.
And sorry, just
No, go ahead.
quickly on if a school is receiving a grant and they have results from this survey, is that, for example, that's an example of how one project has been funded in a school for how much the school's receiving? Do we know yet what they are spending their money on?
So in terms of this report is based on the E1 survey.
Yeah.
So this is a population level report, anonymized report. All the schools, individual schools who have participated have received an individual report and confidential report, which we don't have access to. So depending on the need, they were given a grant. A grant was, I think, from 6 to 8K per school. So if they needed more physical activity, they have invested in that. So we are monitoring that as well, how they are going to use that. If they have used that already. Health and well-being has come out as the top push that schools have utilized. So and I think in terms of the evaluation, so those individual reports for the schools who participate on year, for North Kensington schools or every other year. So they will receive that report, and we will receive the whole sort of population level report, so we can see the changes in terms of any interventions that we as a result of that. So, and we will be evaluating at the end of the 5 years survey the changes. Just on the in terms of the impact, just wanted to add that before publishing this report or bringing it here, we were socializing the findings with our for consultation purposes, and we were redesigning our children and young people substance misuse service in RWKC. And as a result of that, we identified the need for mental health and health and well-being workers have been recognized as a need and has been put into the new spec. So they will be part of the service.
So this is someone within a school.
It is across all schools.
Thank you for this lovely report. I was just curious to find out how does oral health focuses align with the joint health and wellbeing strategy 2023 to 2033. I'd just like to know in terms of equality prevention and early interventions.
Yes, so our health and wellbeing board strategy is very much around giving every child the best start in life, and having population health data around children and young people helps us feed that into not just the services that we commission as a council, but also into wider NHS services, voluntary sector services, our partners in schools and wider. So it gives us an opportunity to have this as an addendum to our joint strategic needs assessments. And as you know, the Health and Wellbeing Board is responsible for the joint strategic needs assessment. So that's the assessment of the population's health and wellbeing needs. We haven't to date had on this scale an assessment of children and young people's needs, particularly one that is so many voices of children and young people. Oftentimes when we're assessing children's and young people's needs, it's quite targeted work, and it's often work with smaller focus groups that sort of feeds into the development of a service or an initiative. So this is an overview of, for example, every child in year 4 year six, etc., gets the opportunity to contribute this. So not just children who are in contact with the service or children who have a need, but also those children who haven't come into contact with our services yet. So it gives us a much broader perspective and a much broader picture of children and young people than we would otherwise have. It definitely feeds into our school nursing service. So we're responsible for commissioning school nursing. So it feeds into what are the needs that a school nursing service needs to focus on. It feeds into our substance misuse services. So as Smart Serve will recently recommission substance misuse services. Also our children and young people's sexual health services. There were some quite interesting findings in the survey around coercive behaviour and the number of children who've been in a relationship that was coercive. So again, that's quite interesting information for us to be feeding into our children and young people's sexual health promotion services, which we're also shortly about to go out to commission, and feeds into the broader work we do on domestic abuse for and violence against women and girls. So it's very much in that space
So
as
you
well.
think the oral health focus, this aligns with the alignment of the joint health and wellbeing strategy? How does the oral health align with that strategy?
So in terms of children and young people's needs, in our joint strategic needs assessment, and also in our children's health and wellbeing board strategy, in the children's sections of it, you'll see oral health, childhood obesity, and immunisations are three areas that have been particularly identified as a part of that strategy for focus in children and young people's work. So oral health is a particular issue for the whole of North West London, where it's the driver of children's admissions to hospital. So it's something we're particularly aware of from that perspective, but also in terms of lost days at school, lost attendance at school, impact on children's ability to concentrate when they're in the school setting. And our oral health services, we received extra money from the government last year, particularly to implement supervised toothbrushing within our school settings. And we were able to use that money to also look at supervised toothbrushing in early years settings, as well as within the primary school setting. So all of that is very much driven by the overarching health and wellbeing board strategy.
So you've heard the young people's report. You've heard in their own words what they're saying. I mean, what are you going to do differently in order for them to have a more pleasant service process delivery and outcome?
Yeah, so some of the things that we're doing differently, and I think is a little bit different around this, is that schools get that small pot of money to do some really focused work with their children and young people, because they've also now got the voice of their children and young people. And we were able to feed into that in different ways through our own services. Some of the things, as one's already kind of touched on a little bit, so our children's substance misuse service, we've expanded the vaping offer as a part of that children's substance misuse service, because something that Hilary was touching on as well, that illegal drugs also get utilised within vapes. So there's a sort of a read across into that service and how we're expanding and developing that service and the mental health component of that service.
I mean, how do we know we're getting value for money? Who's going to be monitoring, evaluating these sort of, initiatives within schools, considering there's such a high uptake in vaping, as well as substance misuse in those kinds of different children? I mean, how are we going to, what's the baseline are we working from in order for us to know that, okay, this is working, and what can we do to, make it better,
Absolutely, Councillor. So what this survey does is it gives us that baseline. So it gives us something for us to utilise in terms of understanding the effectiveness and the impact of our substance misuse services, of our wider school nursing services, of sexual health services, etc. So obesity services for children, young people, physical activity services. So we'll be able to use this as a baseline moving forward to understand where our children and young people are at, because it's such a significant sample size that we're looking at across our patch, and we'll be able to monitor trends now over years. So as Usman said, we're looking at a 5-year stretch. We've got a 5-year period of time we're looking at undertaking this survey over, and that will give us an opportunity to start to monitor trends. So we've used the report, the baseline this year. So this year's survey kind of really is sharing that baseline with you all. And then over time, we'll look to see trends. And we've also got the opportunity to add questions to the survey over time as well. So if we particularly wanted to understand something better as a result of what children have told us, we can start to incorporate that.
Okay, so along with your experiment and your questionnaire, will be there another service provided so that you can see what's working in parallel? Will they be working parallel with each other?
No, so we're really talking about how we're shaping our existing services in response to what we found in the survey. And a part of our engagement work with schools to encourage schools to partake in the survey, and then to enable schools to respond to the findings of the survey, we offered grants to schools ranging up to £8,000 depending on the size of the school. So a large secondary school, for example, would have got the full £8,000, but smaller schools would have got smaller amounts in line with the size of their pupils.
That comes from the public health grant, not the general fund, just to make sure, because that's not affected by, the public health is a grant that the government will only give us. So just making sure that we're not spending frivolously out of the general fund, given the pressures we have. I just want to make that clarification.
With one resource from the public health grant.
Yes, but that's the case.
Certainly not. I would say our public health grant is one of the most scrutinised pockets of money that we have to look at, and not just by us, but also by OHID, who are the Office for Health Improvement and Health Disparities, who have got oversight of how public health grants are spent across the country. So not only do we answer to our residents and to our councillors, we also have to answer to OHID for how we spend our money.
So in terms of the workforce, what's going to change now based on what the children have said? What is going to change moving forward after this report in regards to improving the children's health? What's going to change in terms of workforce?
Yes, in terms of workforce, if I just give you an example,
Thank you.
one thing we have done is that we have designed leaflets, and we can share that later with this committee. You said we did. So that is an A4 side of a poster, and in which what the children have said and what we have done about that. And we will be sharing that with the schools, and it's almost designed, ready to go out. Just to bear in mind, this is a perception. This is the children's perception, and may not be entirely accurate. It may depend on their perception at that point in time. So it is also about raising awareness about the services that we already have got in space: our healthy school service, our school nursing service, our health visiting service, not for school, but for not for 5. So other services, Change for Life, and so on. So it's also raising awareness to improve accessibility, not only for children, but also for their families and their parents as well. So we will be doing quite a lot of work in this space. The other thing that we've got is that we've got a Children and Young People, IHD, neighborhood team, which is across the Borough, and which we've got all the stakeholders, including CNCH, we've got the CNWL, we've got voluntary sector. So we have socialized the findings of this report with them, and they will be taking a few actions forward from that. So it is a collaborative report and action system actions that we will be taking forward. We are leading on it with the partner of actions together that we will be on going forward.
Okay, thank you.
Thank you, Madam Chair. Just a few questions really about some of the numbers. So there's quite a few just to pick up. Out of interest, do you ask the children where they live when they fill in the survey? So do we have any idea how many actually live in the borough compared to how many are attending schools in the borough but don't live in the borough?
I'm just casting my mind back to the survey. I believe we do, because obviously in a number of our schools, not all, but certainly in our secondary schools, our pupil community in the school may come from a mix of different local authorities,
So you have
children who live in Hammersmith.
Yeah. we have a rough idea of how many completed survey actually live in the borough.
60-40.
60-40 lived in the borough.
But for
There's
example,
60 lived out of the borough,
Yeah,
well, for secondary schools.
yeah,
Okay, but of that, almost 2,000 have completed the survey.
Yeah.
That's primary as well.
It's primary as well, yeah.
primary as well.
Yes, that's
Nearly
right.
2,000
So it wouldn't have been
children.
60-40 for them.
So
That would be
when
much
I was,
more.
I'll speak to what I recall when I was in Children's Services. So for secondary schools, yes, we've got a big proportion of people who live outside the borough who attend
Yeah.
secondary schools, only because there's only 6 of them, state funded anyway. The primary schools, we've got more, about 35 of those. Most of those are local children, like in the vicinity of the catchment area, except for Cardinal Vaughan, which is London wide, that was slightly different. But since there's minimal, there's fewer secondary schools than primary schools. Therefore, that's the reason why they come from out of borough more so than in the borough. In the borough, I should say.
Yeah, I just wanted to know roughly how many. And just out of interest, do you do a similar report or survey in our independent school? I mean, given that almost 50% of children in the borough go to independent school, I mean, I'm slightly concerned here that we have a survey that is obviously, in many cases, probably looking at people who are more in need, but where you have probably cases of a huge sway, like I said, almost 50% of our children who are not being asked their views or what the issues are, or, what sort of problems they're having.
So no, we don't do the survey in independent schools. We're only doing it in the state schools as it is. There would and there could potentially be the option for independent schools to participate in the survey, but many independent schools have got their own mechanisms for collecting data information, and if they were to do so, then we would ask them to contribute to it.
So do you ever talk to them about their data and ask that to be fed into your findings and your work, or is there a great wall of China between the two?
No, well, no, we don't. But there certainly isn't a great wall of China. Just to reassure you on that. And actually, our independent school do contact children's services for all sorts of reasons in terms of areas of vulnerability and need. So, and they are also invited to our designated safeguarding lead forum, for example. So, if you like, there's a recognition that they're all our children.
I agree with Roberta as well. I mean, but the similar issue with health too. So many people, like with home care, many people, which is why it gets fewer and fewer home care providers as it goes down, because people who need them, who can afford them, will go privately. So we don't have any data for that. We don't have any data for vaccinations for people who go privately. So our vaccinations overall are lower because many people do that all overseas. We just don't have that data either. Same with independent schools that we just don't, because they don't come through our purview. They come from our purview in terms of safeguarding and things like that, but not in terms of day-to-day operations. And there's we can't compel them to share that information either.
No, of course, but I'm just concerned that, we're talking about a report of our children's views, and 50% of children in this borough aren't being asked their opinions. So I would suggest gently perhaps that in future years, there might be some scope to look into, I appreciate not making the whole report about children who, and as you say, they've got their own services, but at least having some sort of conversations there, or a part of the report that does include that, because it does seem like a gate-wide hole. Just in terms of that, then moving on to emotional well-being. I mean, 25% of primary pupils being bullied to me seems quite high. I mean, maybe I just look like a roach in spectacles, but I don't really remember. I remember people being a bit mean, but I don't really remember that much bullying going on when I was. And unless it was a society, our kids are now much more horrid than they used to be. How are we defining bullying? What are we teaching kids that bullying is? And I guess a lead on to that, when they say they see something online that is upsetting, what do we consider to be upsetting?
Well, I think this is very much about their perception and listening to them, about their direct experience in terms of what they've felt to be unkind, something that someone said, something that someone has done, something that's been shown online. So it's very much their perception. You could look at this the other way as well. I think it is, maybe in past years, children and young people might have felt a little bit more reluctant to say how they're feeling and what they've experienced, but we're developing, and it's well developed in many of our schools, where children feel comfortable to come forward to share what is upsetting them, what they're feeling uncomfortable about. Because we want to have our schools as safe spaces where children can talk about these sorts of issues. In addition, though, I think the flip side is supporting them to develop strategies, ways forward for resilience as well, and knowing how to manage situations, how to talk things through. Schools do a lot of mediation work between children where things have happened and to resolve it as well. So yeah, you could look at it.
Yeah, I mean, I guess my concern would be better, at what point do we fall into sort of an over-diagnosis thing where something happens to someone and someone would normally just brush it off their shoulder and think, well, that's just like, whatever. And now we're saying, oh no, you really should be upset by that. That's
No.
bullying. Are you sure you're not upset?
No, just to challenge that slightly, we don't approach children to say, that must have upset you, but we want to listen and make sure that they've got someone they know, a trusted adult that they can talk to in school about any issue that may be worrying them. And when we were talking earlier to Councillor, thank you, about, well, how will we know? I think it's also recognising this is my constant bedtime reading with the revised and renewed Ofsted inspection arrangements, where it's a requirement in terms of spiritual, moral and social and cultural development for children. That's really important. And we were saying earlier about prevention and social cohesion and understanding and contributing to everyone's overall well-being, and for children to feel happy in school and in our communities. So yeah, there'll be other people looking about what schools are doing, and this initiative is over the next 5 years is really going to help schools and enable them to deliver even more.
I mean, I guess I was a school governor, and I know at the time, state primary school, and the parent governors are talking about the number of children who are suffering from anxiety because of climate change. And my concern is that there may be, or has a tendency to perhaps overburden some children with issues and things and that's where I'm sort of thinking that, and I would be interested, I mean, is this bullying, is that when you ask them, are we asking about bullying from other pupils, or, if my teacher told me off not doing my homework, could I be considered bullying?
Anything that they find, difficult or experienced as.
Right. Okay, and then next up was on I think on the coercive, you mentioned coercive relationships, 26%. So they experience controlling behavior when in a relationship. Again, you might tell me that my friends are just incredibly nerdy and when we were at school just lose this clearly, but I mean, I struggle to believe that of the year 8 and 10, that 26% had even been in relationships, let alone had controlling. Is that, again, parents included in that, or teachers?
To an extent, but I think it's relationships in terms of controlling. It doesn't necessarily mean a relationship that we might be considering as adults, but friendship,
right?
Where they've got themselves caught up in things being quite coercive or controlling.
Do you give any examples as part of do they ever, as the survey, would they say, I'm going to control it, yes. This is the
well, I think what we can have with our.
I'm not expecting you to tell me, individual cases.
Well, I couldn't.
No,
that
yes.
would be wrong. But I think it's recognising the vulnerability of some of our children and young people and how they can get caught up in things. It's not always a deliberate decision, but grooming, wanting to be part of what's going on, and getting caught up in things. So, I struggle a bit to remember when I was an adolescent. I just about remember.
With the same age.
Oh, so flattering. But, untrue, but very flattering. But I think that it's to do with how, children and young people want to feel that they belong, want to feel that they're part of something, that they've got friends. That's so important in terms of their whole socialisation. But I think sometimes it's for sure they're getting caught up in things where they could be exploited, and we know that, and the vulnerabilities associated with it. And I don't think it's necessarily that our children and young people are making the best informed decision. They don't recognise it. They don't feel they're being exploited.
Right.
Does that answer? And
Yeah, kind
Oh, okay.
of, I guess. And then, I mean, the other thing that to me I found slightly shocking, that 63% of Year 6 people said they found school lessons on good friendships and relationships quite or very useful.
Yeah.
I mean, I think it's slightly tragic that people needing to be taught what a good friendship should be. I mean, it's surely to me that's endemic of something that's a greater problem somewhere where there's something in our education system that's going wrong.
Well, I don't think it necessarily
But-
means that there's a deficit there, but allowing our children to talk together about what a positive and lovely friendship looks like. And if you, I'm not saying you haven't, but if you see those kind of activities in schools, it's something to be highlighted. They want to talk about it. They want to talk about what's positive.
I'm going to move on to Gerald.
Cool.
because
Yeah, that was my last one, I think.
Well, yeah, we slightly moved on. I was wondering the question of independent schools in the borough, because if you look at the topics, relationship, sexual health, all emotional well-being, alcohol, smoke, those are cross schools, aren't they? There are issues at the back. Now, just again, really, just you asked the question, really, just how well. This is a great report. How every public school in the borough gets a copy of this report. Whether they do anything with it is a different thing. But there are lots of stuff in here that, and maybe some of those public schools need some of this more than the state schools in terms of being more open up and more emotional issues and that sort of thing. Yeah.
Yes, thank you for that. And I think whilst we can't deliver everything to independent schools, what we do is provide the resources and the information about other organisations like Booth. That's just one. And we're also, sorry? That's an independent voluntary organisation that supports children where actually it's the children themselves and the young people who can determine they contact them direct. And it's the sort of thing we're not too far away from it now, are we, in terms of our children getting ready to take GCSEs and A-levels and exams. That will be happening very soon as we come to the lead in after the Easter break. So I think it's about making sure that that information is made available. We're going to share it because, as you say, but we're not necessarily going to get to the survey.
I guess we have to pick up the pieces, don't we? If these things don't go well with our children, whatever school they've been to, it's a danger they come back into needing services to help when this has gone wrong.
100% right. So it is about prevention as well.
Yeah,
absolutely is looking upstream.
Taking from a mother, it's not the same out there since I was a child.
Yeah, absolutely.
Yeah, I think Roberta needs a lesson in that one. Well, I see that one person, and it's sort of slightly off, who I visited recently in Holland Park School, and I don't know if you've come across this, Louis, who is being commissioned by the Kirsty and Chelsea Foundation. And I've met him now twice, and I've now gone around the project, but also had him present. And it totally blew me away, the transition he is making to those children. And he's not a teacher. He's essentially, he's being brought in as a non-teacher, but some of the kids were talking about the difference in their lives, the 6 months he's been there, sort of their anxiety or how confident they're feeling and how much what they want to do when they're older. And he's essentially their safe space, which they go to him in their break times, they go to him at lunch, he's got his whole pack. If you could commission a Louis in every single school, I think
But you're right, but there are other services as well, our community safety team locally. My colleague Tom Hodge, he goes around schools and it's talking to the young people, and it's nothing against teachers at all. Part of my job working with them in schools. But actually, the value placed on that partnership, working with other people who are not teachers,
I think
other people that can come in and talk to them about what's happening out there, and listening to them as well about what's happening in our communities, how it's making them feel, because it is a very different world.
Because, and I didn't need to ask now, she spoke a question before I got in, but what does PHSE look like these days? Because these are results of the areas that you would hope that would be coming up in those sections, and that people are
Very broad, PHSE, and now we call it SMSC. Yes, which is about spiritual, moral, and social and cultural development. So it's much broader. It does incorporate what used to be PHSE.
but is that in terms of what people are coming in contact with online, what reading, I mean, where
As
they're
part of
condoms,
the-
which was brought up in this, all of those topics, is that being incorporated into consistent?
It has to be, sorry, I cut across you because it has to be part of the curriculum. So required.
So what else is part of that broader S&M, SE lesson?
SNP.
It varies.
You know the initials again.
Yes, exactly. Yes, SMSD. But it includes all sorts of things like citizenship, how you make a contribution to society, about your own sense of identity and your purpose and respect for other people. And yeah, so it's much, much broader than what we're talking about here, although it's key and part of it.
It sounds like there's a lot to cover in those lessons.
There is definitely a
that's
lot to
okay.
cover, which is why
Yeah.
when, and we have had some inspection teams coming into our schools recently with the new inspection framework, and that's why they're running round a lot over just over 2 days, and exactly the same for our schools. So it is in the public domain, but we've had a number of schools that have gone through the inspection experience through this renewed arrangement. So what you will see is they get a grading for this area of work. So Holland Park schools now on the public domain, it's on the school's website, schools like Hartwalk Primary School, so by primary school there.
They're ones that have struggled.
Sorry?
They're ones that have struggled, or
No.
they put what they're teaching in the public.
No, their inspection report
Right.
with their gradings.
But they did well. They all did
The
well.
Ofsted.
Yeah.
And they're all doing okay for more than 8 6.
What
Thank
they did
you.
well, I must say. Well done to them.
Absolutely. Congratulations to them. It's a good
Well, thank you very much for this report, and
It's a
I
pleasure.
assume maybe in a year's time you'll come back with yeah.
If any buzz it can share, but I'm sure.
With some information on independent school as well.
I'll be delighted.
But thank you, that's really interesting.
Yeah. Thank you so much.
Very interesting. Thank you.
Sharing where it goes. Next item is agenda item 6, which is the suicide prevention working group report. I am very pleased to present the final report on suicide prevention, focusing on adult males and high groups. This was a very interesting piece of work involving 2 committee members, Councillor Hargreaves and Councillor Ahmed. This evidence shows a clear pattern. Around 3/4 of those who died by suicide are men. What also stayed with me from the evidence sessions is that many men do not access support until very late, especially when they are struggling with their emotional well-being. While there is a great deal of excellent clinical support by statutory agencies support, we also heard about the importance of everyday community settings such as bars, pubs, sports clubs, gyms, and workplaces in suicide prevention. As chair, I think we need to think carefully about how we reach men in these places, as these community touch points can play an important role in helping them feel able to talk and noticing when someone may be struggling. Before I ask members to make contributions, can I ask Anne-Marie and Councillor Randall to say anything you would like to add?
Thank you.
About
Thank you, Chair. And I'd like to thank, obviously, the committee and the working group that really kind of delved into this. I think some of the stuff that has been recommended is really good. I think those recommendations, I think we can all pretty much accept that. It's all very good in regards to that. But I think you're right, especially around the male suicide. It's been an issue, but highlighting it here, I think it's been extremely well done. your suggestion by essentially changing your opening remarks about how to access men with perhaps mental health needs or anxiety or whatever, or suicide, or targeting places where you may be more free to open and speak.
Yeah.
I think it's really, really important as well. And trying to prevent this as much as possible from the I think many of us have sort of been impacted by someone who they know, especially a young man who has taken his own life. And that's always such a realization when that actually happens. But I think there is societal effort to challenge some of those challenges. But I think what is in the report, I think it's good. I've got Anna and Seth here as well to help answer some questions specifically on that. But well done to the working group.
Thank you to my fellow colleagues who spent much time on it.
So may I introduce Safia to the committee? Safia is one of our heads of public health. I said Safia is very much the champion behind all of our mental health, emotional and suicide prevention work with the team. So we appreciate your thing. And I would just like to add my thanks to Councillor Reynolds to the committee for focus on this really important topic. I think we've got some really clear practical recommendations moving forward. There's really good alignment with our suicide prevention strategy. And we particularly welcome the recommendation around engaging more males, more men in our voluntary sector initiatives, and particularly in places where men frequent, for example, barbers, perhaps, sports clubs or gyms, communities, etc. So really
Potentially pubs as well, but I know that's very anti-health.
I think pubs are really important.
Yeah, they are. Yeah.
As
much as they perhaps encourage other vices of this life. But absolutely, Chair, I agree with you with that.
If you want to add again.
No, I think we've been on a journey with the suicide prevention work, and I'm really excited to see how this next phase of the next 3 years is going to evolve. We've done a lot of foundational work in terms of the Stay With Us campaign, providing that one-stop shop on our website around all the services that provide. But now we've placed the foundations there, and now we're moving on to that engagement, that co-production in relation to the high-risk groups, especially around men. We understand that there's an average of 14 deaths per year. That's one, it's too many. 14 we have still got work to do. But I think the team is very committed, and we are committed to make a difference. And we're quite excited about the next ones now in the next 3 years.
No, I would just love for the work we've done here to sort of, obviously we have all the sort of normal services and you have to have on the website, but I think the reality is that if someone is having suicidal thoughts or going through a terrible time, and is male, what we found out and is very clear is they don't necessarily go looking for where they are seeking help, and I don't think they would go to the council website. I appreciate that is what we have to do, and I just really hope we think a bit more out of the box about how we could be either providing a training program or reaching out into pubs, sports centres, gyms, workplaces, and actually providing training to people, so whether they become community champions, whether they sort of are people who know their regulars who come each week, and they can be monitoring when something is different or a certain behaviour. Because I think the reality is, if we just look at this in traditional methods, men don't come forward in traditional ways in the same way they don't speak like women do to their female friends. So if we're not sort of sparking those conversations in different ways, I don't know, we're just going down the same route. And so I really, really hope, if I'm on this committee, if I sort of see in the future that we can be either if it's partnering with the voluntary sector or just doing things differently, offering training in places which we never would usually, because reality is they're the people who can help without people and when they need the help.
And I think access and how people access, and that's why things like pubs are so important. And I mean, the barbers, that's separate barbers. It's just really, young men don't go to statutory services as their first point of call. And I think that whole what the voluntary sector offers is and non-statutory services is crucial to get to this group of people. And the methodology actually years ago when I was involved with the service that we started introducing emails support and the number of men increased. And then when we started introducing texting support, the number of younger people, but also people in more desperate need, much more active suicidal. So it's a different ways that people can access and a way that they, particularly younger men, feel more comfortable doing it. And public sort of statutory services, and of course there has to be a place for it, but they're not always the best to get to this category.
I think that's right, Gerard. I think from my experience as well, as I said at the start, you know someone, I think you'll know someone I said who has unfortunately been suicidal. Then they're not proactive in saying there's something wrong. It's kind of breaking down those barriers, especially in a social setting, to eventually get they're comfortable to mention something, get something out. That could take a while.
Yeah.
But you've got to, I think, for us to get people in a position where they feel comfortable and confident to do that, because there's always a stigma. It's always this kind of, in my view as well, element of it is weak if you. It could be a very subjective possession. Obviously, no one would think that happens, but how that if you're struggling with something, financial issues, health issues, or whatever it's going to be, how you kind of approach that. And I think, like you're right, Gerard, I think it's just finding those right avenues to do it, because people aren't going to ring up their GP, or people aren't going to hop into a drop-in centre, because that's just not how it's going to work in reality.
But that's why point one of the recommendation I think is so important. Just things like language that you use.
Yeah.
I mean, we don't hopefully talk about people committing suicide.
Yeah, exactly.
Nonsense gone, hopefully. But you know, it is important in terms of helping people to feel more comfortable about talking about it.
What did you say about committing suicide?
Taking the life of themselves.
Yeah.
Committing suicide is linked to when it was a crime. But you're committing a crime by killing yourself. And hopefully over time we've little things, and it's easy to say, well, that doesn't make any difference, but there are little things that go to build up, making people feel slightly more relaxed about talking about these things.
And I think from moving on from what you just said, Josh, is that's why I think the members of our community, we could get on board as part of this project, hopefully project I'm imagining in my head, that I would love you to do, is because I think if you have people who know they're regulars, they know it doesn't necessarily mean they're coming out, they need to say anything, but it's just if you see someone on a regular basis,
Yes, of course. Yeah.
and they are trained to know what they might be looking out for, or just if actually someone is maybe deteriorating or not in a good place, then it's actually saying, look, I know about this service, I know you can go here, I can get different forms that aren't maybe intrusive, and I think that type of training would be really advantageous too.
I think it was something we're really keen to explore. There are some examples of where bar staff have been trained
Yeah, exactly.
to listen and to know how to refer people. There's been projects with peer maps in pub settings, what's on the back of toilet doors and
Exactly,
knowing where people can go. And so all of those are areas we're really, really keen to explore as we move forward. And we're very much keen to engage with men as well, to have those conversations too. I think it also links back a little bit to our previous item on children and young people. A lot of the work in schools about having children talking about what are committed friendships, what are healthy relationships, and talking about your feelings. That's all early mental health promotion that is important for how we develop throughout our life, and then how we become resilient adults.
Yeah, no, definitely.
But in Aldborough, hotels are another key place, training hotel staff.
Yes.
We working with environmental health to train people who work in hotels, so they are able to identify signs, but also to safeguard themselves, because you never know what they're walking into. And we're working with licensed premises as well in terms of providing that support behind toilet doors,
and also being able to identify the behaviours that could actually, where they can actually get help in to be able to support the individual. So there's initiatives happening across the council, across the services, and but you're right, it's about making sure that it isn't only about people being able to talk about this, their suicide ideation and being able to talk about their feelings. It's being able for us as residents, friends, companions, being able to have the conversation but feel comfortable. Because as soon as someone mentions suicide or suicide ideation, or I feel like taking my life, some people still are uncomfortable with it, but also the stigma attached to faith community. So that's another challenge. I mean, we've worked quite hard with Faith Action to create a resource to be able to break down that stigma. So the next phase in, how do we teach our faith communities that it's okay to talk about it and utilise the faith resource to give them confidence about the scriptures and what it says around well-being, about taking your life, but also being able to communicate with their parishioners who come into their sort of faith, place of faith.
Thank you, Chairman. Just, do you have any demographic breakdown of interest on Anti-Root?
We do have the demographic breakdown, and if I recall, and I'm happy to go back and get the information, but in Kensington and Chelsea, it's predominantly white males.
Yeah.
And then at a low
Bankers who've lost a lot of money.
Sorry.
Bankers who've lost a lot of money.
Right.
Is it middle-aged? Is it mainly middle-aged women, professional men, or are you finding? I mean, what are the sort of demographics that you're finding?
In terms of that breakdown, I don't recall having that, but we have it in terms of ethnicity. We have it in terms of gender and age.
So I would have thought, just not to interrupt, on in terms of the faith, I'd have thought faith groups presumably much less likely, just because of the inherent beliefs in faith groups. I would have thought they might be less likely to be people that do suicide than take their own lives than people who aren't.
So what's interesting about the faith groups is how suicide has been reported. It's also been seen as a barrier. So we understand that when families talk about suicide, if they're linked to a very close-knit community or faith community, they will sometimes not declare that their loved one has taken their own life, and it's because of the stigma that's attached. So in terms of that faith community being able to reach out to that family and that individual, they will reach out in the terms of bereavement, but in terms of that specialist suicide support of losing someone through this way of, it's sometimes very difficult. So we understand that there's a stigma within the faith community and within the community itself on how that family is seen. And so sometimes it isn't declared. And even when it goes to the coroner's level, the family asks whether or not that could be sort of not reported.
And do they remove it? Or?
I don't think they remove it, but I think what they do, they find a way to record it that doesn't place stigma on that family.
So do you think these numbers are underrepresented then, the number of suicides in the report? Would they be lower than what the actual number is?
So we get the data from the ONS data set, and we understand that with the data itself, there could be a level of underrepresentation. And it is all reliant on the coroner's report. So these are things that we understand that throughout the whole country, that reports might be less because of whether or not it's been recorded as suicide. We understand that if someone takes their life, it does impact on insurance.
Well, coroners have got much better than recording it, because in years gone by, it was recorded as suicide, often life insurance companies didn't pay out. The coroners have got much, it's still an issue, but they have got better over the years.
Reported so they can pay insurance, or so that the insurance policy isn't invalidated, the coroners don't report it, or how?
Yes, I mean, that's got better, and coroners are much better at reporting death by suicide as a suicide rather than something else.
There's the insurance companies have changed their less signatory.
Yes, yeah.
And just out of interest, because I think when the chairman said in the introduction that, I can't remember the percentage of suicides that were male suicides, 3/4. But then under point 7, men are less likely to attempt to commit suicide than women. I was just wondering what that discrepancy was.
That doesn't sound right. Where is it?
Paragraph 7.
7, it does
Men are
say-
less likely to attempt to
Men are
commit
less likely
suicide
to
than women.
Yeah, but I think keyword is.
Oh, I think that
Yes, please.
Yeah. But from looking at point 7, it talks about how
Okay.
they have taken their life. And one of the discussions is that men tend to take their life in a much more direct way to end their life. And women tend to take a much more a non-direct approach. Yeah. And I think
When it's not successful, are you trying to say?
yes,
Yeah.
so there's less likelihood
Yeah.
of women being more successful, if I'm right, James.
Mm-hmm.
Right. So I think that's something that we could sort of tweak
Yeah.
a bit just to be represented. But I think this is more or less around the how rather than that.
Thank you.
Other questions?
As you touched on a very interesting point about, and we haven't touched on here because it wasn't part of our brief, but survivors of suicide and the families that are left behind. There's a whole other area of support needed there, and they're often not neglected, but they don't get the support they need.
It can be more vulnerable themselves.
Very vulnerable. Yeah.
Well, I was going to ask about that, and also whether we then speak to family. That's incredibly difficult, but whether we speak to families afterwards and understand if those people have had support, maybe we've just completely missed them. Maybe the ones who have been successful in taking their own life, you've never even got to them, because often it's a big surprise, right? Yes. So, and maybe we can learn from those cases. So as part of our engagement in our first, in the before strategy, and one of the things we did engage with families, especially through the faith resource, about, lessons learned, how can we support and so forth. So there is engagement with, through lived experience with family of the bereaved. In terms of what support do they get, as soon as they're notified, as soon as the police are notified of the suicide, they have a protocol in place which automatically refers the individual to bereavement support, such as Mind, to be able to reach out immediately to the family to provide support. So there's support there through the police and there's support there through Mind itself. Additionally to that, so that's a long term, that isn't just within 24 hours, that's over a period of time that Mind will provide support to that family in terms of their bereavement, in terms of the shock. But also there is a charity we've identified that is able to support anyone who witnesses an attempt of life or suicide, such as on the underground, such as standing, on a pavement and someone takes their life. So there is that support there, and all those services are placed on our page. And I totally understand that, it's not normally the first port of call that someone will go into, but it might be a first port of call for frontline service.
Yeah.
It might be a point of call for a worried parent or worried partner, trying to establish help, locally and what to provide that.
No, I think it's so important to have. I just think it's not necessarily where they're going.
No, absolutely.
If you take like tube drivers, I think I haven't got the figure to mind, but less than 10% of tube drivers that have experienced a suicide while driving a tube, only 10% return to work or something. It's minute. Because if you were the driver, that's the knock-on effects of these are phenomenal.
Any further comments from anyone? Well, thank you very much, and thank you to Jared. One of us not here, but it was not an easy sort of number of meetings. They were very heavy, but I hope it's.
Thank you. Thank you, Chair, and thank you. Obviously, we're at the last hurrah
Yeah.
of this 4-year term, the last of this committee, or last of the member potentially. Just like to obviously thank everyone for your support and scrutiny, of course, over the last few years. Obviously, thanks to Councillor Hargreaves. 16 years. Is this sort of your last meeting
It is.
ever?
It is. Well, maybe not ever in
Well,
life.
no, it was last council meeting.
You've been coming back as an audience.
But yeah, thanks for all your obviously service the last 16 years and 2 as mayor. And Roberta as well, thank you. Been amazing, as you can tell from the room. You are such good questions. Obviously, a great member for Queensgate. And yeah, hope to see you soon. And everyone else, good luck. That's all I can say.
Yeah.
And see how we go.
Thank you.
Thank you.
Thank you, Josh,
Thank you very much.
Josh, for all your hard work and all of you. Thank you. We do actually have one final thing on our agenda, which you don't have.
No, exactly. That's why it's my farewell speech now.
Which is in a way to spend the work program report. The report is an update on the select committee's work program for the community fiscal year 2025-2026. It identifies items which could be taken forward into the year for the meeting in June. Do members have any issues they would like to put forward?
Given that nobody knows if we're going to be here.
Right.
Well, let's think we know we won't.
Let's think of the really tough issues.
Yes, yeah.
It's to help the next committee. So someone will be here.
I do think we're good at this. I do think follow up. We get a lot of nice reports, and I think I mean, a question to you else tonight that let's make sure that these things are followed up. Because reports can look really, you know, people can construct reports to look really good, but do they actually happen? And what happens? I think the follow-ups are crucial.
Completely agree with that. Particularly as sort of, for example, home care in the next sort of 2 stages that Gareth mentioned. That should go on the list, but I think he was saying just before a year and then after it. So kind of noting things like that we should sort of hopefully they can put that back. But I mean, I've looked through this. I think it's a good starting point. I mean, there will be.
Chair, I was wondering if there's any interest at all in having the major local hospital providers, HL West, come in for the first meeting. We obviously
this from the last meeting when I heard of it.
Well, no,
that was
they're
we have heard a lot from the commissioners and the ICB, but so we've heard probably a bit less from like our big local hospital institution. And obviously this committee has an important role to ensure that there's good quality standards of the local hospitals, that there's a good patient experience, and there's good safety monitoring as well. So that might be for a new committee potentially as a first meeting. That would be a good.
I think that's a good idea. And
I think also emerging issues, you know, because they're at the forefront of it, aren't they?
You never know. I mean, meningitis hopefully will not be on the radar in June, but any situations, I think to generally just monitor anything that's spiking to see if there's any kind of emergency issues that need to be brought forward.
But not just emergency, general trends in healthcare and
even on a day-to-day basis, operationally, I think it's needed improvement.
Okay.
And also with the move from the Aberdeen.
So that
kind of thing.
Well, that's a separate issue. So I think that's another thing that the new committee will have to keep an eye on is the transition of children's cardiac and respiratory services from the Royal Bronson to the Evelina, which Councillor Knight was told last week will be starting in May. So that's something that a new committee will definitely have to keep its eye on. What's happening with that?
So I think just really
okay.
They can kind of monitor how.
So that's something to.
Where is the Evelina?
It's one of the bridge. It's in
Lambeth.
the Borough of Lambeth.
parking permit doesn't work good.
Yeah. But that's fine. I'll contact say Chel West and see if they I know, the first meeting in June, they present their quality accounts or
I think that's
other
good.
information about what's going on the boards, the youth services.
I do think you need to find a way, and I appreciate this, particularly with the NHS, because they don't do the data, but report after report after report that we've had has not included anything.
We did
to do
write
with,
a letter to
independent.
West Streeting on this.
yeah, private healthcare, or even like tonight, our independent schools, right? And I particularly, I mean, the schools, I accept that we're not going to be going and spending public health money on in independence, most independence for the most part, but to have a report on children that excludes almost 50% of the children in our borough, I think is slightly farcical. So I think there needs to be, even if you're not doing every school, but a way of more holistically looking at the demographics of the whole borough, because this borough is so different to your average borough in the rest of the country. There needs to be some thought when obviously preparing reports or doing a survey or something. And again, I appreciate it's harder with external stakeholders like the NHS or the ICBs or whoever they are who are collecting some of this data to find a way to give us a whole, because otherwise you get those terrible headlines like we're the worst in the country for vaccinations or something, which is obviously codswallop, but it's just because they're not counting most of the people.
Yeah, I think when the committee got into the data about that particular issue around vaccinations, I think that the emerging underlying narrative came out.
Yeah, but I think we just need to keep I mean, I appreciate it's not going to be, me being here and being grumpy, it's not going to solve it, but if conversations you have, well, you can have conversations with other officers and other teams of trying to always keep it at the forefront of their minds as well. Because the worst thing is, what we don't want is bad headlines in this council and bad publicity and other things. And also for us to sit here and read a report that at the end of the day doesn't include half the borough.
Yeah,
it's not.
I mean, on that point about vaccinations, we Councillor Knight did write to the NHS, and we actually heard back
We wrote
from the chief executive. So that's as high as it can go. So
they couldn't. They were going to keep it on. They said they were aware of the issue and they wanted to keep.
But it went as high as it can go. So they are. You did make your views known.
It's as with so much in politics. If one wrote one letter and let it go, nothing would ever happen. One has to be, the way, and even the local government or national government, whatever, the way being it by being a pain in the backside.
No, I think that's a fair point, but I think it applies to anything in open scrutiny that we see, or a lot of things that you have to keep on coming back to.
Yeah,
you have to keep
keep
on making your case.
Absolutely.
Yeah.
I think also on those issues, because where it goes wrong, we have to pick up the pieces. So if public schools are not doing their duties in these areas, if the private health people are not doing their duties properly, we have to pick up the pieces off them, don't we? And it costs us money and time.
And it would be worth, obviously you've sent it out now, for example, maybe it's a lead member thing or maybe it's something for Councillor Knight. But there would be other boroughs, I mean, there's not many obviously, but in London in particular, Westminster, presumably Camden, I think is another that have. I mean, when it comes to schools, I'm thinking a very high number of kids in independent education, but presumably will have similarly high or slightly less high, maybe Richmond, in terms of healthcare, private healthcare and vaccinations, that stuff. Trying to reach out to our counterparts in those boroughs to get them to start banging the same drum, because you think they have the same, it's in their interests just as much as it is. Right? I think it's very easy for us, and travel across the country, various reasons, it's very easy for local authorities to be siloed and, not think of outside our own borders. And so I think things like that, where, as you say, we can write a letter and get that bobbed off with as high as it can go. But then getting other people to write in and say that, they're in the same position and wanting it, sort of snowballs.
Yeah, I completely agree.
But that's the problem for the next lot. So.
Well, thank you.
Thank you for chairing it so well.
And thank you to James for helping support me at all times. And now we can close this meeting. Thank you to everyone for your time and attendance. And to Gerald and Roberto's potentially our last meeting.
Thank you, Chair.
Thank you.
Thanks, Greg.
Oh,
Well, we quorum at 4. Is that still quorum?
Course is 3.
for your
Really?
Yeah, of course.
10.
Very low, actually, isn't it, Corbin?
Yeah. Why did you get promoted? Why are you on the top table?